Welcome to the Deep Dive. Our mission is simple, and it's tailored just for you. We take a stack of source material, we sift through it, and we extract the most important insights, the absolute key nuggets of knowledge, to help you go deep and reach that elite professional level of understanding on the topic at hand.
That's the goal.
Today, we're embarking on a deep dive into a chapter that might seem deceptively simple on the surface, but our source material quickly reveals its profound importance. We are diving into Chapter 46 of a major medical text, focusing on diarrhea and constipation.
Right, topics that everyone encounters, but the depth is, well, significant.
Okay, let's unpack this. Why are we dedicating a whole deep dive to these conditions? The source makes it abundantly clear. These aren't just minor discomforts. They represent a massive global health and economic burden. We're talking about conditions that are incredibly common, with acute episodes alone affecting over 1 billion people worldwide each year.
1 billion. It's a staggering number, and the impact goes way beyond just feeling unwell. It's mortality, especially acute infectious diarrhea in developing countries that tragically accounts for around 1.8 million deaths every single year. And infants are hit hardest.
Wow.
Yeah. But even putting that aside, it's the sheer morbidity, the disruption to daily life, the significant social inconvenience, the lost work productivity, and the enormous consumption of healthcare resources.
That resource consumption really jumps out from the source. In the U.S. alone, acute diarrhea costs over $8 billion annually, and that figure excludes inflammatory bowel disease, which adds significantly more. Constipation, too, is a major drain, with an average cost reported around $3,500 per patient. So yes, these are symptoms, but they point to a vast, complex, clinical picture.
Precisely. And the source stresses that even seemingly mild or typical symptoms can, in fact, be important red flags for serious underlying issues. We're talking about potentially life-threatening conditions like colorectal cancer or systemic disorders that manifest in the gut, like, say, thyroid disease. So to provide rational, cost-effective, and truly excellent care, understanding the underlying pathophysiology, the diverse causes, how to accurately diagnose and how to manage these conditions is absolutely crucial.
That's our mission today for you, to equip you with that detailed understanding, to think about these common complaints like the elite professionals in this field do, seeing beyond the symptom to the intricate biological processes involved.
Exactly. And to truly understand what goes wrong, we first need to appreciate the remarkable complexity of what goes right. So we have to start with the foundation, the normal physiology of the small intestine and colon.
Let's begin there. What are the primary roles of the different parts of the gut in their healthy state? What are they supposed to be doing?
Okay, so the small intestine's main job, its primary function, is really digestion and assimilation of nutrients. It's where the vast majority of breakdown and absorption happens. But working together, the small intestine and the colon are absolutely essential for regulating water and electrolyte balance. They're constantly secreting and absorbing them in this dynamic interplay. They also store and transport contents through the system, and the colon has a vital role in salvaging nutrients. It does this through bacterial metabolism of unabsorbed carbohydrates, producing short-chain fatty acids.
And those are important.
Very. They're a key energy source for the colonic lining cells themselves.
The source material highlights that the motor functions, how contents move through, differ significantly between segments.
They really do. When you're fasting, the stomach and small bowel are dominated by this synchronized thing called the migrating motor complex, or MMC. You can think of this as the gut's housekeeper.
The housekeeper, I like that.
Yeah, it's a highly organized, propagated wave of contractions that sweeps through the small intestine roughly every 60 to 90 minutes. It only lasts about 4 minutes, but it clears out non-digestible residue, helps prevent bacterial overgrowth, and just generally keeps things tidy down there.
So it's actively pushing stuff forward even when you're not eating.
Exactly. But after you eat, the pattern shifts dramatically. The MMC basically gets shut off and replaced by irregular sort of low-amplitude mixing contractions. These primarily churn the food and digestive juices to maximize contact with the intestinal lining for absorption.
Okay.
There's an exception, though. The distal ileum, right before the colon, still has more powerful intermittent contractions. This allows it to function as a sort of reservoir, emptying contents in boluses like little packets into the colon rather than a continuous stream.
Ah, okay. And the colon's motility is different still.
Yes. Totally different rhythm. The colon's primary activities are irregular mixing contractions, which helps with fermentation of carbohydrates by resident bacteria and significant water and electrolyte absorption. Transit times are much slower and vary by segment. Well, the ascending and transverse colon are mainly reservoirs. They hold contents for an average of about 15 hours. That allows for thorough mixing and absorption. Then, the descending colon acts more like a conduit, moving things along much faster, maybe about 3 hours transit. And finally, the sigmoid colon and rectum form the volitional reservoir. That's where stool is stored until, it's appropriate to defecate.
Understanding these normal patterns is clearly foundational to recognizing when things go wrong.
Absolutely. Alterations in how the gut handles fluid and electrolytes are the core mechanisms of diarrhea. Similarly, many cases of chronic diarrhea, as well as IBS and chronic constipation, stem from disturbances in the motor and sensory functions of the colon.
Here's where it gets really interesting for me. The source emphasizes that the gut isn't just a passive tube controlled by the brain. It has its own sophisticated nervous system.
Yes. This is the enteric nervous system, or ENS, the intrinsic innervation of the gut. It's this vast network, like a mesh, right within the gut wall, made up of myenteric, submucosal, and mucosal neuronal layers. The myenteric plexus, sitting between the muscle layers, is primarily involved in regulating smooth muscle function, coordinated contractions. It's heavily influenced by these special cells called interstitial cells of Cajal. They act like the pacemakers for gut motility.
Pacemakers in the gut, wow.
Yeah, and the submucosal plexus, that influences secretion, absorption, and mucosal blood flow. What's truly remarkable, and you touched on this, is that the ENS can coordinate complex gut functions. Yeah. Motility, secretion, blood flow, largely independently of the central nervous system.
It's often called the second brain.
For good reason. While it definitely receives input and modulation from the brain, it has the capacity to run many processes locally. It uses this complex cocktail of neurotransmitters, the sourceless acetylcholine, vasoactive intestinal peptide, VIP, opioids, norepinephrine, serotonin, ATP, nitric oxide, NO, and tachinins like substance P. It's an incredibly rich and complex local signaling environment.
And then there's the extrinsic innervation, the input from the brain and spinal cord via the autonomic nervous system.
Right. That system sort of modulates the ENS and provides the overarching control. The parasympathetic nerves coming via the vagus nerve to the small intestine and proximal colon, and sacral parasympathetic nerves to the distal colon. They carry both visceral sensory information from the gut to the CNS and excitatory signals to the gut, primarily using acetylcholine. Those sacral fibers are fascinating because they actually send ascending projections up the colon from the pelvic plexus.
And the sympathetic nerves, what's their role?
They generally run alongside the arteries and have a modulating effect.
Yeah.
Classically, you think of them as excitatory to the sphincter muscles, like the anal sphincter, tightening them up, and inhibitory to the non-sphincteric smooth muscle in the gut wall, relaxing it.
And how does the gut communicate back to the brain to tell it what's going on? I'm full, or that hurts.
That's through the visceral afferents. These are sensory nerves that convey information about distension, chemical changes, pain, and other sensations from the gut back up to the CNS. Some of them even synapse in prevertebral ganglia outside the CNS, allowing for really rapid localized reflexes that can modulate motility, blood flow, and secretion without you even being aware of it. It's a multi-layered control system.
Local reflexes, spinal cord, brain complexer?
Very.
Okay, let's turn our attention to the movement of fluid and electrolytes, which is absolutely central to understanding diarrhea and, in reverse, constipation. The daily volume numbers involved are huge.
They really highlight the incredible efficiency of the gut's absorption machinery. On average, about 9 liters of fluid enter the GI tract every day.
9 liters? That's a lot.
It is. That's from what you drink and eat, plus significant secretions from salivary glands, stomach, pancreas, liver, the intestine itself, all adding up. But out of that 9 liters, only about 1 liter typically reaches the colon, and the normal stool output, a mere 0.2 liters per day, about 200 milliliters.
So the small intestine absorbs about 8 liters, and the colon handles the last liter, leaving just a tiny fraction to be expelled. That's amazing efficiency.
Exactly. The small intestine does the heavy lifting, recovering the vast majority of fluid and nutrients. But the colon, while receiving much less volume, is remarkably efficient and has a substantial reserve capacity. The source highlights that the colon can recover up to 4 times its usual volume, meaning it can absorb maybe over 3 liters per day, maybe 3.2 liters if needed.
Wow. Provided
the rate of fluid delivered from the small intestine isn't overwhelming. This significant reserve allows the colon to partially compensate when the small intestine isn't absorbing as effectively.
How does this absorption happen at the cellular level? How does it actually pull the water back?
Well, the absorption, particularly of sodium, is predominantly electrogenic. You can think of it like an electrical current flowing across the cell layer. Sodium ions are taken up at the apical membrane, that's the side facing the gut lumen, and then pumped out the other side. the basolateral membrane, by the sodium-potassium ATPase pump. This constant pumping creates a driving force for water absorption to follow.
And this is tied into nutrient absorption in the small intestine, right?
Very much so. In the small intestine especially, active transport proteins on that apical membrane couple the entry of sodium with the entry of nutrients like monosaccharides, glucose via SGLT1, fructose via GOUT5, and amino acids. The energy from the sodium gradient helps pull these nutrients into the cell.
Ah, co-transport.
Exactly. Once inside, glucose, for example, exits the cell on the basolateral side via other transporters like GLUT2. This movement of solutes creates a concentration gradient and an osmotic gradient, which passively pulls water and other electrolytes out of the gut lumen and into the body, following those solutes.
So if you can't absorb these solutes, maybe you're missing an enzyme or something, they stay in the lumen and hold on to water.
That's the core principle of osmotic diarrhea, which we'll definitely get to later. On the flip side, secretion is also a vital process, and dysregulation of secretion is key in many diarrheal diseases. Chloride secretion in particular is mediated by several channels, and figure 46:1 in the source explicitly illustrates this. Key players include the CFTR channel, the cystic fibrosis transmembrane regulator, which is defective in cystic fibrosis, and the CLC2 channel, a type 2 chloride channel.
And these channels and transporters are targets for medications. I see figure 46:1 mentions some drugs.
Absolutely. That figure is important because it shows how some medications used to treat constipation, particularly the secretory agents, work. You have GCC receptor agonists like linaclotide and pecannatide, which stimulate secretion. Then there are NHE3 inhibitors like Tendaban, or NHE3 is the sodium-hydrogen exchanger, so inhibiting it blocks sodium absorption. And lubiprostone acts on both the CIC2 channel and seems to affect NHE3 as well.
So understanding these specific players, NAG3 for Na plus absorption, DRA for ClHCO3 exchange, NKCC1 involved in transport, shows us the molecular levers we can pull therapeutically, or how these processes can fail in disease.
Precisely. Gives us targets.
And colonic fluid balance has its own layers of control. It's not just the channels.
No, it's also regulated by local mediators, cholinergic, adrenergic, serotonergic signals, all integrated by the ENS, that local gut brain. Interestingly, systemic hormones like angiotensin and aldosterone also influence colonic absorption. The source notes this might be related to the shared embryologic origins of the colon and the renal tubules in the kidney.
Fascinating connection. Okay, we touched on small intestinal motility, the MMC, in fasting, mixing after eating. What about the transition zone, the ileocolonic region? That seems important.
It is crucial for storage and salvage. The distal ileum acts as that intermittent reservoir we mentioned, emptying contents in boluses. This pause gives maximum time for the small intestine to complete absorption and salvage remaining fluids, electrolytes, and nutrients before the less permeable colon receives the contents.
And the colon structure itself contributes to function. Those pouches, the haustra.
Yes, the segmentation into haustra compartmentalizes the colon. This facilitates mixing of the contents with the resident bacteria and the colonic mucosa, promotes further absorption, and helps form solid stool. This is also where the luminal ecology, the gut microbiome, plays such a vital role.
Ah, the microbiome.
Yes, predominantly anaerobes, these bacteria are essential for fermenting unabsorbed carbohydrates. This fermentation produces those short-chain fatty acids we mentioned earlier, not just nutrients for the host, but they also influence motility and secretion. Plus, the normal flora contributes to host defense by competing with and suppressing potential pathogens.
So the health of the microbiome is really integral to normal gut function.
It's a critical interaction, and honestly, we're only beginning to fully appreciate its complexity. And again, different regions of the colon function differently. The ascending and transverse colon are the main reservoirs. The descending colon is the conduit. The colon's remarkable efficiency in conserving sodium and water is particularly important when the small intestine isn't functioning optimally, helping to prevent dehydration.
And if any of these motor, sensory, or absorption secretion processes are disrupted, that's when symptoms arise.
Exactly. Diarrhea or constipation can stem from problems anywhere along the line: altered reservoir function in the proximal colon, disrupted propulsive function in the left colon, or, particularly for constipation, issues with the rectal sigmoid reservoir, the pelvic floor muscles, the anal sphincters, and the coordination of defecation, often exacerbated by factors like dehydration impacting stool consistency.
Let's look closer at colonic motility and tone. Besides the mixing contractions, there are those powerful waves you mentioned.
Right. While the small intestinal MMC rarely continues into the colon has its own strong propulsive events. high-amplitude propagated contractions, or HAPCs. These are contractions over 75 mmHg, much stronger than the mixing contractions. And they're associated with mass movements, where a large segment of colonic content is rapidly propelled forward.
And these happen regularly.
Normally, they occur about 5 times a day, often triggered by waking up in the morning or, importantly, after eating. That's part of the gastrocolic reflex.
And problems with HAPCs can cause symptoms, like things moving too fast.
Yes. Increased frequency or strength of HAPCs can lead to rapid transit, causing diarrhea or a strong sense of urgency. Colonic tone, the baseline background contractility, is also important. Phasic contractions are superimposed on this tone. The tone influences the colon's capacitance, how much volume it can hold comfortably without triggering reflexes, and also affects sensation.
You mentioned the gastrocolic reflex eating stimulates colonic motility. How strong is that effect?
It's pretty significant. Both phasic and tonic contractility in the colon increase after a meal. This is largely mediated by the vagus nerve, responding to distension of the stomach. However, it's not just any meal. It requires a certain amount of caloric stimulation, typically at least 500 kilocal, and it's partly mediated by hormones like gastrin and serotonin released in response to food.
Finally, before we get to the problems, the complex act of defecation. The source includes figure 46-2, which maps this out nicely.
Yes, that figure is excellent for visualizing this. Continence, the ability to hold stool, is maintained by a few key factors. Normal rectal sensation, so you know when the rectum is full, and the tonic ongoing contraction of 2 muscles, the internal anal sphincter, which is involuntary smooth muscle, and the puborectalis muscle, a voluntary skeletal muscle.
The puborectalis sling.
Exactly. It forms a sling around the rectoanal junction, creating an acute angle, typically 80 to 110 degrees. This angle acts like a physical kink or valve, helping to prevent accidental leakage.
So to defecate, you have to consciously relax that system. Or is it automatic?
It's a combination of involuntary reflexes and voluntary control. When the rectum fills, its distension triggers a transient relaxation of the internal anal sphincter that's an intrinsic reflex. If it's appropriate to defecate, signals via sacral parasympathetic nerves cause the voluntary puborectalis muscle to relax. This is crucial. Relaxing the puborectalis allows that rectangle angle to straighten out by at least 15 degrees. At the same time, the perineum descends, typically 1 to 3.5 centimeters.
And then pressure helps expel the stool.
Yes. Voluntary contractions of the sigmoid colon and rectum increase pressure, and voluntary straining, like the Valsalva maneuver bearing down, also increases intra-abdominal pressure, which further helps open the rectosigmoid angle, usually by more than 15 degrees. And finally, the external anal sphincter, which is voluntary striated muscle controlled by the pudendal nerve, is consciously relaxed in response to the sensation of rectal distension, allowing the stool to pass.
And you can override this if it's not a good time.
Absolutely. If it's not the right time or place, you can voluntarily contract the external anal sphincter and the puborectalis muscle, which increases the rectonal angle again and delays defecation. It's a really beautiful interplay of automatic reflexes and conscious control when it works right.
All right, that's the intricate, healthy machine. Now, let's dive into what happens when things go too fast. Diarrhea. The source defines this for adults as the passage of abnormally liquid or unformed stools at an increased frequency, generally quantified as a stool weight of more than 200 grams per day.
Right, that 200-gram cutoff is sort of the objective measure. And duration is key for classification. Acute diarrhea lasts less than 2 weeks. Persistent diarrhea is 2 to 4 weeks, and chronic diarrhea lasts more than 4 weeks. This distinction is crucial because it dramatically changes the list of likely causes and how you approach the diagnosis.
The source is careful to differentiate true diarrhea from conditions that might present similarly but are fundamentally different, things that patients might call diarrhea.
Yes, it's vital not to confuse true diarrhea with pseudodiarrhea or fecal incontinence. Pseudodiarrhea involves the frequent passage of small volumes of stool, typically less than 200 grams total per day. Patients feel constant urgency, tenesmus, that feeling of needing to go even if the rectum is empty, and report incomplete evacuation. This is commonly seen in conditions like irritable bowel syndrome or fructitis, inflammation of the rectum.
So it feels like diarrhea because you're going often, but the total output is low.
Exactly. Low volume but high frequency is pseudodiarrhea. Fecal incontinence, on the other hand, is the involuntary discharge of rectal contents. This is primarily a problem with the muscles and nerves controlling the anal sphincters and pelvic floor, often due to neuromuscular disorders or structural damage. While severe diarrhea and urgency can certainly overwhelm sphincter control and cause incontinence, the underlying issue in primary incontinence is the loss of voluntary or reflex control itself.
And there's also overflow diarrhea.
Yes, This typically occurs in patients, often elderly or debilitated, who have severe fecal impaction. Hard stool builds up high in the rectum or sigmoid, and liquid stool produced further up the colon literally leaks around the impaction. A simple rectal exam can usually detect the impacted stool. So, distinguishing these low-volume frequent stool, pseudodiarrhea, involuntary loss, incontinence, and leakage around a blockage, overflow from true high-volume diarrhea is the first step, and it relies heavily on a detailed history and physical exam.
Let's focus specifically on acute diarrhea, the sudden onset, usually short-lived episodes. What's the main driver?
Over 90% of acute diarrhea cases are infectious in origin. Non-infectious causes do exist, things like toxins, ischemia, food reactions, medications, but infection is by far the most common culprit.
And how do these infections typically occur? How do people get them?
The vast majority are acquired via the fecal-oral route, often through contaminated food or water. The source highlights the crucial role of the resident gut flora in healthy individuals. They typically suppress invading pathogens. Disturbances to this delicate balance, often by antibiotics, can allow pathogens like Clostridium difficile to flourish.
So our own bacteria protect us usually.
They do, along with other host defenses, gastric acid-killing bugs, digestive enzymes, protective mucus, peristalsis, rapidly moving things along these defenses, have to be overwhelmed for a clinically significant infection to take hold.
The source provides key associations for specific pathogens and lists important high-risk groups. This seems vital information for directing investigation.
Absolutely. Knowing the clinical context narrows the possibilities dramatically. Travelers are a prime example. About 40% of individuals traveling to endemic areas think Latin America, Africa, Asia, develop travelers' diarrhea. Most commonly caused by E. coli, particularly E-tech or EAEC strains, Campylobacter, Shigella, Aeromonas, norovirus, coronavirus, and Salmonella.
Any specific locations or activities?
Yeah, Giardia is a risk for travelers to certain areas like St. Petersburg, Russia, or for wilderness campers drinking untreated water. Norovirus is notorious for rapid spread in contained environments like cruise ships.
Food is another major vector. We hear about outbreaks all the time.
Connecting the diarrhea to specific food consumption is incredibly important. Did multiple people get sick after the same meal? Chicken is a common source for Salmonella, Campylobacter, and Shigella. Undercooked hamburger is strongly linked to that nasty enterohemorrhagic E. coli 0157, H7. Bacillus cereus often pops up with reheated fried rice. Staphylococcus aureus and Salmonella can contaminate mayonnaise, creams, and egg dishes. Salmonella from eggs themselves. Listeria can be in raw or frozen foods, mushrooms, dairy. Vibrio is linked to raw seafood. Public health networks like PulseNet, which tracks bacterial DNA fingerprints, are critical for identifying these foodborne outbreaks.
Immunocompromised individuals are at much higher risk. You mentioned infants earlier.
Yes, absolutely. Whether it's due to primary deficiencies like IgA deficiency or CVI, or secondary causes like advanced age, AIDS, chemotherapy, or immunosuppressive medications. Common pathogens often cause more severe or prolonged illness in these individuals. In AIDS specifically, opportunistic infections are frequent culprits. Mycobacteria, viruses like CMV, adenovirus, HSV, and protozoa like Cryptosporidium, Isospora, Microsporidia, Blastocystis. Anorectal issues are also common in AIDS from venereal infections.
And the source mentions a specific risk with hemochromatosis.
Right. Individuals with hemochromatosis and iron overload disorder are uniquely susceptible to severe Vibrio and Yersinia infections. They should be strongly advised to avoid raw seafood or exposing open wounds to seawater.
Daycare settings and institutions also see high rates. That makes intuitive sense.
Yeah, daycare centers are, hotbeds for transmission of Shigella, Giardia, Cryptosporidium, and rotavirus among children, and then spreading to their families. In institutional settings, especially hospitals and nursing homes, infectious diarrhea is a common nosocomial or healthcare-associated infection. Clostridium difficile is the most frequent culprit there. And importantly, C. diff can also be community-acquired and occur even without a recent history of antibiotic use, though antibiotics are still the major risk factor. Table 46-2 in the source material is a really valuable resource because it links the specific pathophysiology, how the bug causes disease, to the clinical features you see. This helps you narrow down the possibilities based on the patient's actual symptoms.
Let's walk through some of those key distinctions from the table. How do the different mechanisms present?
Okay, think about toxin producers first. If the toxin is preformed in the food before you eat it, like with Bacillus cereus, Staphylococcus aureus, or Clostridium perfringens, the incubation period is very short, just 1 to 8 hours. The hallmark is marked vomiting, often more prominent than the diarrhea, With minimal or no fever and a really abrupt onset, bam, you're sick.
Okay, preformed toxins equals fast onset, lots of vomiting. What if the bug makes the toxin inside you?
Right. If the pathogen produces an enterotoxin after ingestion, like Vibrio cholerae, enterotoxigenic E. coli, E. tech, Klebsiella, or Aeromonas, the incubation is longer, maybe 8 to 72 hours. There's usually less vomiting here, more cramping, and often higher fever. Both types cause profuse watery diarrhea by stimulating hypersecretion in the small bowel, just dumping fluid.
What about pathogens that adhere to the gut lining but don't necessarily invade or produce those powerful toxins?
These are the enteroadherent types, like enteropathogenic E. coli, EPEC, enteroaggregative E. coli, EAEC, Giardia, cryptosporidiosis, and some worms, helminths. They typically have a slower onset, maybe 1 to 8 days. Vomiting is less common, but pain and bloating are prominent. Fever is usually low or absent, and the stool is typically watery or mushy, maybe moderate severity, 1-2 plus on a scale.
Cytotoxin producers sound like they actually damage the cells.
They do. These pathogens, like Clostridium difficile and hemorrhagic E. coli, produce toxins that directly injure the gut lining cells. They cause fever, often moderate, 1 to 2 plus, and severe abdominal pain, 3 to 4 plus. The diarrhea is usually watery, but can sometimes be bloody, 1 to 3 plus. A key point for hemorrhagic E. coli is that the diarrhea often starts watery and then rapidly becomes bloody. Incubation is generally 1-3 days for C. diff and shorter, 12-72 hours for hemorrhagic E. coli.
And then there are the truly invasive organisms, the ones that actually penetrate the gut lining. The source subdivides these based on how much inflammation they cause.
Right. Organisms causing minimal inflammation, like rotavirus and norovirus. Very common viruses typically cause vomiting, 1 to 3 plus, pain, 2 to 3 plus, often high fever, 3 to 4 plus, and watery diarrhea, 1 to 3 plus. Incubation is quick, 1-3 days. Then you have pathogens causing variable inflammation, including Salmonella, Campylobacter, Aeromonas, Vibrio perihemolyticus, and Yersinia. These have a wider range of symptoms. Vomiting can be absent or significant, 0-3 plus. Pain is moderate to severe, 2-4 plus. Fever is usually high, 3 to 4 plus, and the stool can be watery or bloody, 1-4 plus. Incubation is quite broad here, anywhere from 12 hours up to 11 days.
And severe inflammation often means dysentery, right? Blood and mucus.
Precisely. Pathogens like Shigella, enteroinvasive E. coli, EIEC, and the amoeba Entamoeba histolytica cause less vomiting, 0-1 plus, but severe pain, 3 to 4 plus, high fever, 3 to 4 plus, and typically bloody diarrhea, 1 to 2 plus. That's the classic presentation of dysentery. Incubation is 12 hours to 8 days. The source adds a specific clinical pearl about Yersinia, noting that it often invades the terminal ileum and proximal colon, causing pain severe enough to mimic appendicitis. This highlights how understanding the specific location of infection can provide diagnostic clues.
And infectious diarrhea isn't always limited to the gut. There can be significant systemic manifestations, effects elsewhere in the body.
This is a crucial point to remember. The body's response to infection can have effects far beyond the site of invasion. Reactive arthritis, historically known as Reiter's syndrome, involves a constellation of symptoms, arthritis, urethritis, conjunctivitis, occurring alongside or following infections with Salmonella, Campylobacter, Shigella, and Yersinia. Yersiniosis itself can also trigger autoimmune phenomena affecting the thyroid, hard pericarditis, and kidneys, glomerulonephritis.
And the really life-threatening complications.
Hemolytic uremic syndrome, HUS, a severe condition with high mortality affecting the kidneys and blood, can be triggered by enterohemorrhagic E. coli 0157.H7 and also Shigella. Post-infectious IBS, where gut function remains altered long after the infection clears, is a recognized complication. Also, an episode of acute gastroenteritis can sometimes be the event that unmasks or precedes the diagnosis of underlying chronic conditions like celiac disease or Crohn's disease.
So it might seem like just a bug, but it could reveal something deeper.
Exactly. And finally, acute diarrhea can actually be a prominent symptom of systemic infections like viral hepatitis, listeriosis, legionellosis, or even toxic shock syndrome. So a thorough systemic review is always important, especially if things seem out of proportion.
Beyond infections, what are the other causes of acute diarrhea? The non-infectious ones.
Medications are arguably the most common non-infectious cause. If acute diarrhea starts shortly after a new medication is introduced, that's a prime suspect. The list of potential culprits is vast: antibiotics disrupting flora, cardiac drugs like antiarrhythmics, antihypertensives, NSAIDs, certain antidepressants, chemotherapy agents, bronchodilators, antacids containing magnesium, and of course laxatives themselves if someone takes too many.
Ischemic colitis is another one mentioned, especially in older patients. What's that?
Yes, this typically occurs in people over 50 and can be due to a blocked blood vessel, occlusive, or just temporarily reduced blood flow, non-occlusive to the colon. It classically presents with acute lower abdominal pain before the onset of watery diarrhea, which then often becomes bloody. It usually affects the sigmoid or left colon, but notably tends to spare the rectum.
Any other acute non-infectious causes to keep in mind?
Sure, acute flares of colonic diverticulitis can cause diarrhea. Graft versus host disease in transplant patients can affect the gut acutely. Toxins from various sources, organophosphate pesticides, certain mushrooms like amanita, arsenic can cause acute diarrhea, often with significant systemic symptoms. Preformed toxins in seafood, like ciguatera from algae or scombroid due to excess histamine in improperly refrigerated fish, also cause acute onset symptoms. Severe food anaphylaxis can present with rapid onset diarrhea alongside other allergic symptoms. And as we touched on, even chronic inflammatory conditions like IBD can sometimes have an abrupt, severe presentation that mimics acute infection.
So, a wide range of possibilities. How do you approach a patient presenting with acute diarrhea? The source includes a diagnostic algorithm, figure 46.3, to guide you.
The very first step is deciding whether evaluation is even necessary, because many cases are mild and self-limited. That decision is based on the severity and duration of the diarrhea and important host factors. Mild cases in otherwise healthy individuals typically don't need an extensive workup.
But there are clear situations where you do need to investigate.
Definitely. There are clear indications where evaluation is necessary. Profuse diarrhea with signs of dehydration, like dizziness, low urine output, frankly, bloody stools, high fever, say 38.5 degrees C or 101.3 degrees ever higher, diarrhea lasting more than 48 hours without any sign of improvement, recent antibiotic use, which raises high suspicion for C. difficile, if the person is part of a known outbreak, severe abdominal pain, particularly in patients over 50, raising suspicion for ischemia or other serious causes, or if the patient is elderly, maybe 70 or older, or immunocompromised. These groups warrant a much more proactive approach.
In some situations, the source suggests you might consider empirical treatment treating based on suspicion even before getting a definitive diagnosis.
That's right. For moderately severe febrile diarrhea, especially if there are indicators of inflammation in the stool, like fecal leukocytes seen under microscope or high calprotectin levels, or gross blood, the source suggests you might consider an empirical antibiotic trial while awaiting results, or even instead of initial diagnostic studies, depending on how sick the patient is and the clinical urgency.
What would that involve?
This would typically involve a quinolone, like ciprofloxacin, for suspected febrile dysentery, invasive bacterial infection, or metronidazole if giardiasis is strongly suspected based on exposure history, like recent camping or specific travel.
But if a severe infectious cause is suspected, microbiologic analysis of stool is the bedrock of diagnosis.
Absolutely, it's the cornerstone. This involves sending stool samples for standard cultures, looking for common bacterial pathogens like Salmonella, Shigella, Campylobacter, E. coli 0157-H7, direct microscopic inspection for ova and parasites like Giardia, Entamoeba histolytica, Cryptosporidium, and immunoassays or molecular tests for specific targets like Clostridium difficile toxin, rotavirus antigen, or Giardia and E. histolytica antigens.
How do you decide which tests to order? You don't just order the whole panel on everyone, right?
No, definitely not. The clinical and epidemiologic associations really guide the choice. If the history strongly suggests food poisoning from a specific source, you might focus cultures on likely culprits. Travel history points towards different pathogens. Recent antibiotic use makes C. difficile testing absolutely essential. Special cultures might be needed for specific E. coli types, Vibrio if they eat raw seafood, or Yersinia.
And the source mentions molecular diagnosis.
Yes, this is increasingly used. Molecular diagnostic panels test for multiple pathogens, simultaneously using their unique DNA or RNA sequences. These can be faster, more sensitive, and potentially more cost-effective than ordering multiple traditional tests, especially with newer microarray technologies becoming available.
What if the diarrhea becomes persistent, lasting 2-4 weeks? Does the approach change?
Persistence beyond 2 weeks raises the likelihood of certain pathogens like Giardia, a very common cause of persistent diarrhea, Clostridium difficile, especially post-antibiotics, Entamoeba histolytica, Cryptosporidium, or Campylobacter. If initial stool studies are negative, the workup might escalate. This could include flexible sigmoidoscopy with biopsies to look for microscopic inflammation, and even upper endoscopy with duodenal aspirates and biopsies, particularly to check for giardia that might be hiding in the small bowel and missed on stool tests, or to evaluate for conditions like celiac sprue. The source also mentions Brainerd diarrhea as a rare cause of persistent watery diarrhea of unknown origin, often starting abruptly after an outbreak and sometimes lasting for months or years.
And structural examination. When do you need imaging or scopes?
Imaging like abdominal CT or specific tests like sigmoidoscopy or colonoscopy are more appropriate for persistent diarrhea to rule out structural issues like strictures, or for suspected non-infectious acute causes like ischemic colitis, diverticulitis, or even a partial bowel obstruction presenting paradoxically with increased output, less common in typical acute diarrhea.
Let's move on to treatment for acute diarrhea. What's the absolute priority, especially in severe cases?
Fluid and electrolyte replacement. This is fundamental and can absolutely be life-saving. For mild cases, simply drinking clear fluids might be sufficient. But for moderately severe or severe diarrhea, prompt use of oral sugar electrolyte solutions is crucial.
Like sports drinks.
Sports drinks have some sugar and electrolytes, but commercially designed oral rehydration solutions, ORS, are generally preferred because they have an optimal composition, often isoosmolar or slightly hypotonic, to promote absorption most effectively. These help replenish water and electrolytes lost in the stool. For patients with profound dehydration, particularly infants and the elderly who are most vulnerable, intravenous rehydration is necessary to rapidly restore circulating volume. Dehydration is the major cause of mortality from acute diarrhea, so this is critical.
What about medications to slow things down or reduce secretion? Things like loperamide.
Anti-motility and anti-secretory agents like loperamide can be helpful adjuncts for symptomatic control in moderately severe, non-febrile, and non-bloody diarrhea. They can reduce frequency and urgency, making people feel better. However, there are important cautions. Yes, they should generally be avoided in febrile dysentery, that bloody high-fever diarrhea, because they can potentially prolong the duration of infection or even increase the risk of systemic complications by basically trapping invasive pathogens in the gut. They should also be used cautiously with drugs that inhibit their metabolism, as high loperamide levels can have cardiac toxicity. Bismuth subsalicylate, like Pepto-Bismol, can also reduce vomiting and diarrhea, but it contains salicylated bismuth, so it should be avoided in immunocompromised patients or those with renal impairment due to the rare risk of bismuth encephalopathy.
Okay, so use antimotility drugs carefully. What about antibiotics? When are they actually used?
Antibiotics are not indicated for most cases of acute watery diarrhea, which are often viral or caused by non-invasive bacteria that don't require them and resolve on their own. However, judicious use is appropriate in selected cases, as outlined in Figure 46-3, to reduce the severity and duration of illness, especially in proven or strongly suspected invasive bacterial infections.
Like the empirical use we discussed.
Right. Empirical use, before identifying the organism, is sometimes considered in those specific scenarios of moderately severe febrile dysentery. Otherwise, antibiotic selection and dosage should ideally be based on the specific pathogen identified, local antibiotic resistance patterns, and the patient's clinical condition. Newer agents, like nitazoxanide, may be needed for organisms like Giardia or Cryptosporidium that are less responsive to older drugs or in resistant cases.
Are there specific patient groups who should receive antibiotics regardless of how severe the diarrhea seems once a bacterial cause is suspected or identified? Maybe someone with salmonella?
Yes. The source notes that antibiotic coverage is indicated even if a specific bacterial organism hasn't been definitively found, or if an organism like salmonella is found, which doesn't always require treatment in healthy adults, in certain vulnerable groups. This includes immunocompromised patients, individuals with mechanical heart valves or recent vascular grafts, due to the risk of bacteria seeding these sites, or the elderly.
Is antibiotic prophylaxis ever used to prevent diarrhea, like for travelers?
Bismuth subsalicylate can help prevent travelers' diarrhea and is often recommended. Antibiotic prophylaxis is generally reserved for a very select group of travelers going to high-risk countries, where the risk or consequences of acquiring diarrhea are particularly high.
Who would that be?
This includes immunocompromised individuals, those with inflammatory bowel disease, hemochromatosis, or gastric aclohydria, low stomach acid, where normal host defenses are compromised. Agents like ciprofloxacin, azithromycin, or rifaximin can significantly reduce the incidence of bacterial travelers' diarrhea, often by around 90%. However, the source emphasizes that rifaximin, a non-absorbed antibiotic, is specifically for uncomplicated traveler's diarrhea caused by non-invasive bacteria and should not be used if you suspect invasive disease, like febrile dysentery.
What role does endoscopy play in acute diarrhea? Getting a scope.
Generally, very little in routine acute diarrhea. Its role is primarily limited to specific situations, such as evaluating immunocompromised patients with persistent symptoms, or when there's a strong suspicion of a non-infectious inflammatory process like IBD or ischemic colitis that isn't clear from other tests.
And a final public health consideration from the source.
Yes, it's crucial for clinicians to be aware of and vigilant for potential outbreaks. Identifying and promptly reporting clusters of cases to public health authorities is critical for controlling the spread, identifying the source, and reducing the overall impact on the community.
That's a really comprehensive look at acute diarrhea. Now let's make the transition to chronic diarrhea, which the source defines as lasting more than 4 weeks. This sounds like a completely different ballgame, diagnostically and therapeutically, compared to those acute cases.
Absolutely. It's a whole different mindset. In contrast to acute diarrhea, which is predominantly infectious, chronic diarrhea is usually non-infectious and requires a systematic evaluation to identify the underlying cause, which could be a serious pathology. The source emphasizes that classifying chronic diarrhea by its underlying pathophysiologic mechanism is incredibly helpful for directing the diagnostic workup and guiding management. Table 46.3 in the source provides this classification. And it's important to remember that many diseases can actually cause diarrhea through more than one mechanism.
Okay, let's dive into the mechanisms, starting with secretory causes. What does that mean?
Secretory diarrheas are fundamentally caused by an imbalance in fluid and electrolyte transport around the intestinal lining, where secretion into the lumen outweighs absorption out of it. Clinically, these are characterized by watery, typically large volume stools. A key distinguishing feature is that they are generally painless and, critically, they persist even when the patient is fasting.
They keep going, even if you don't eat.
Right, because the gut is actively pumping out fluid. And because the excess water in the lumen isn't being held there by malabsorbed solutes, if you measure the stool osmolality and subtract the contribution from typical stool electrolytes, sodium and potassium, there's no significant osmotic gap, usually less than 50 mosmol.
And what drives this excessive secretion? What causes it?
The source lists medications and toxins as the most common cause. Hundreds of prescription and over-the-counter drugs can stimulate secretion or impair absorption. A really important category to consider, especially in unexplained cases that just won't quit, is the surreptitious or secret use of laxatives.
People taking laxatives without telling anyone.
Exactly. Particularly stimulant laxatives like phenolphthalein, less common now, bisacidil, anthraquinones from senna, cascara, or castor oil, ricinoleic acid. Chronic heavy ethanol consumption can also induce a secretory-type diarrhea by injuring enterocytes and altering transport. Environmental toxins like arsenic can cause chronic secretory diarrhea. Persistent bacterial infections, even after the acute phase, can occasionally contribute. And the source specifically points out that olmesartan, an oral medication for high blood pressure, is associated with a sprue-like enteropathy that causes secretory diarrhea.
Inadequate absorption surface can also look like secretion you mentioned earlier, like after surgery.
Yes, significant bowel resection or extensive disease or fistulas connecting parts of the bowel inappropriately can lead to inadequate surface area for absorption.
Right.
While fundamentally a reabsorption defect, the net effect is excessive fluid in the lumen. Unlike other secretory diarrheas, this type often worsens with eating because delivering more fluid load to a compromised reabsorptive surface just increases output.
And specifically removing the end of the small bowel.
Right. Disease or resection of less than about 100 centimeters of the terminal ileum is a classic example. This impairs the reabsorption of bile acids. These dihydroxy bile acids then escape into the colon and directly stimulate colonic secretion, leading to what's called cholorheic diarrhea or bile acid diarrhea.
And bile acid diarrhea isn't always due to surgery or obvious disease?
Correct. So-called idiopathic secretory diarrhea or bile acid diarrhea, BAD, where bile acids are functionally malabsorbed from a terminal ileum that looks structurally normal, is increasingly recognized. It accounts for a significant chunk. The source says an average of 40% of previously unexplained chronic watery diarrhea.
How does that happen?
The proposed mechanisms involve dysregulation of the enterohepatic circulation of bile acids. Maybe there's reduced negative feedback on liver synthesis by a hormone called FGF19, or genetic variations in the hepatic receptors for FGF19, beta-klotho and FGF4, or maybe genetic variation in the bile acid receptor TGR5 in the colon. leading to accelerated transit and impaired absorption. Still being worked out.
Paradoxically, obstruction can also increase fluid output. That seems counterintuitive.
It does, but yes. A partial bowel obstruction, a stricture, like narrowing near an ostomy site, or even severe fecal impaction can lead to upstream fluid hypersecretion above the blockage. This is likely due to distension and stasis triggering secretory reflexes, resulting in increased fecal output that might be perceived as diarrhea, but is technically secretory driven by the backup.
Hormones are classic examples of secretory causes, though often rare in practice.
They are the classic textbook examples, definitely, though overall uncommon. Metastatic gastrointestinal carcinoid tumors, or rarely primary bronchial carcinoids, can cause watery diarrhea, sometimes as part of the full carcinoid syndrome with flushing and wheezing. This is mediated by the tumor-releasing secretagogues like serotonin, histamine, prostaglandins, and kinins.
Gastronoma. That's usually ulcers, right?
Usually refractory peptic ulcers, yes, due to massive acid secretion stimulated by gastrin, but diarrhea occurs in about a third of patients and can be the only symptom in 10%. The diarrhea here is often due to fat maldigestion, because the very low duodenal pH inactivates pancreatic enzymes, though other secretagogues from the tumor might contribute too.
And the vipoma sounds like one of the most dramatic causes, like pancreatic cholera.
It truly is dramatic.
Yeah.
Vipoma, usually a non-beta cell tumor of the pancreas, secretes VIP, vasoactive intestinal peptide, and other peptides. It causes the WDHA syndrome, watery diarrhea, hypokalemia, achlorhydria. Often the diarrhea is massive, commonly over 3 liters per day, with reports of up to 20 liters.
20 liters?
Yes.
Wow.
It leads to life-threatening dehydration and severe electrolyte imbalances, particularly low potassium, causing neuromuscular issues like weakness or paralysis. Other features can include low magnesium, high calcium, flushing, and hyperglycemia.
Any other rare hormonal causes worth mentioning?
Medullary thyroid carcinoma can cause watery diarrhea due to calcitonin, other peptides, or prostaglandins, often seen with advanced metastatic disease and unfortunately associated with a poor prognosis. Systemic mastocytosis, typically identified by those characteristic urticaria pigmentosa skin lesions, can cause diarrhea that is either secretory, histamine-mediated, or inflammatory due to mast cell infiltration in the gut. And large colorectal villus adenomas, a rare type of polyp, can secrete large amounts of fluid and electrolytes, causing secretory diarrhea and hypokalemia. This is often mediated by prostaglandins and can sometimes be inhibited by NSAIDs.
There are also very rare congenital defects mentioned from birth.
Yes, extremely rare conditions presenting with severe watery diarrhea right from birth. Congenital chlorhydria is caused by a defective chloride bicarbonate exchanger, mutated DRA gene, leading to massive chloride loss in stool and metabolic alkalosis. Congenital sodium diarrhea is due to a defective sodium-hydrogen exchanger, mutated NHE3 gene, causing severe sodium loss and metabolic acidosis. These really highlight the critical importance of these specific transport proteins in the gut lining.
And even hormone deficiencies can cause diarrhea.
Yes, Addison's disease, or primary adrenocortical insufficiency, where the adrenal glands don't produce enough hormones, is associated with watery diarrhea, among other systemic symptoms like fatigue, weight loss, and hyperpigmentation.
Okay, moving on to osmotic causes. Here, the problem is unabsorbable solutes in the gut lumen pulling water in, like a sponge.
Exactly. This type of diarrhea is characterized by the presence of osmotically active substances in the stool that are not absorbed. Clinically, the key feature is that the diarrhea characteristically stops when the patient fasts or when the causative agent is discontinued. If you stop putting the osmotic agent in, the diarrhea stops.
Makes sense.
On stool analysis, it's identified by an osmotic gap, typically greater than 50 osmol. The source cautions against directly measuring fecal osmolarity because bacterial fermentation in the stool sample after it's passed can produce new osmotically active molecules, which can skew the results.
Osmotic laxatives seem like the most straightforward example here.
Yes, this is a very common cause. Ingestion of non-absorbable substances found in many laxatives, antacids, or supplements, particularly magnesium-containing products like milk of magnesia, magnesium citrate, phosphates like in bowel preps or sulfates, pulls water into lumen and causes diarrhea. Pretty simple mechanism.
Carbohydrate malabsorption is another big one. You mentioned lactase deficiency earlier.
Absolutely. This occurs when the brush border enzymes in the small intestine don't properly break down certain carbohydrates. The unabsorbed sugars reach the colon and are fermented by bacteria, producing gas, bloating, and osmotically active short-chain fatty acids which draw water in. This fermentation also lowers the fecal pH. Lactase deficiency The inability to break down lactose, milk sugar, is the most common specific cause of chronic diarrhea in adults, affecting a large percentage of non-white populations and a significant minority, maybe 5–30%, of people in the U.S. Symptoms vary depending on how much lactose is consumed.
Are there others besides lactose?
Oh, yes. Other poorly absorbed sugars like sorbitol, lactulose, which actually uses an osmotic laxative, and fructose, found in many processed foods, sugar-free candies and gums, and some medications, can also cause osmotic diarrhea if consumed in large enough quantities.
And the concept of wheat and FODMAP intolerance fits here. How does that work?
The source includes non-celiac gluten intolerance and FODMAP intolerance under osmotic causes, likely because the mechanism involves poorly absorbed carbohydrates and their subsequent fermentation in the colon. Non-celiac gluten intolerance seems associated with impaired gut barrier function in response to gluten. FODMAP intolerance refers to symptoms triggered by fermentable oligosaccharides, disaccharides, monosaccharides, and polyols, basically short-chain carbs that are poorly absorbed and rapidly fermented by gut bacteria. Both can cause chronic diarrhea, often with significant bloating and abdominal pain, and involve complex interactions between diet and the individual's gut microbiome.
Right, the fermentation producing gas and osmotic load. Now, steatorrheal causes involve the malabsorption of fat. What are the hallmarks there?
Right. This is characterized by bulky, greasy, often pale, foul-smelling stools that are notoriously difficult to flush away and tend to float. Because fat isn't being absorbed properly, it carries away fat-soluble vitamins, A, D, E, K, and can impair absorption of other nutrients, leading to significant weight loss and various nutritional deficiencies. The diarrhea mechanism involves both the osmotic effect of fatty acids, especially if they get hydroxylated by bacteria in the colon, and the sheer bulk of the unabsorbed neutral fat in the lumen.
How is steatorrhea actually quantified? How much fat is too much?
Objectively, it's defined as excreting more than the normal 7 grams of fat per day in the stool, usually measured over a 24 or 72-hour collection while on a standard fat diet. The amount of fat can give clues to the cause. Just rapid transit alone might cause mild steatorrhea, maybe up to 14 BD, because digestion isn't completed. Small intestinal mucosal disease typically results in moderate levels, perhaps 15–25 gene diets. Severe pancreatic insufficiency, however, where you just can't digest fat at all, often leads to much higher levels, frequently over 32 gene Ds.
What are the primary mechanisms leading to steatorrhea? Why does fat malabsorption happen?
There are 3 main categories the source outlines. Intraluminal maldigestion, mucosal malabsorption, and postmucosal lymphatic obstruction.
Okay, intraluminal maldigestion, inside the gut tube.
Yes, this means that the problem is with digesting the fat within the lumen of the gut. The most common cause is pancreatic exocrine insufficiency, where the pancreas doesn't produce enough digestive enzymes, particularly lipase. This usually requires a very significant loss of function, over 90%, often due to chronic pancreatitis, frequently a consequence of alcohol abuse, cystic fibrosis, or obstruction of the pancreatic duct. Another significant cause is bacterial overgrowth in the small intestine.
Bacteria causing fat malabsorption.
Yes, when there's stasis of contents, maybe due to anatomical issues like blind loops or diverticula, or just slow motility, dysmotility, especially common in the elderly bacteria, can proliferate in the small bowel where they shouldn't be in high numbers. These bacteria deconjugate bile acids. Deconjugated bile acids can't form micelles properly, and micelles are essential for fat digestion and absorption. So the fat remains undigested. Cirrhosis or obstruction of the bile ducts can also cause mild steatorrhea simply due to insufficient bile acid concentration reaching the gut lumen.
Okay, so that's problems digesting fat in the lumen. What about mucosal malabsorption?
This means the problem is with the gut lining itself, the mucosa, being unable to absorb the properly digested fat. Various enteropathies, diseases of the small intestine lining, can cause this. Celiac disease is the most common, that gluten-sensitive enteropathy affecting people of all ages. Ingesting gluten triggers an immune response that damages the lining of the proximal small bowel, causing villus atrophy and crypt hyperplasia. This flattened lining just can't absorb fats, carbohydrates, and other nutrients effectively, leading to fatty diarrhea and multiple nutritional deficiencies.
Celiac is more common than we used to think, right?
Much more common, affecting about 1% of the population. And importantly, it often presents without classic steatorrhea, instead mimicking IBS or having various subtle gastrointestinal and extraintestinal symptoms. So you have to think of it. Tropicus sprue is a similar malabsorption syndrome seen in people living in or traveling to tropical areas, often with an abrupt onset and typically responding to antibiotics, suggesting an infectious component. Whipple's disease is less common, usually affecting young to middle-aged men. It's a systemic infection with the bacterium Trophorema whippleyi, causing malabsorption plus widespread symptoms like joint pain, fever, swollen lymph nodes, fatigue, and even affecting the CNS or heart.
Any other mucosal causes?
Yes, a similar malabsorption picture can be seen in AIDS patients with disseminated Mycobacterium avium intracellular infection. Abetalipoproteinemia is a rare congenital defect in childhood, affecting the cell's ability to package fat into chylomicrons for transport, leading to severe fat malabsorption, often with associated features like spiky red blood cells, acanthocytes, ataxia, and retinitis pigmentosa. Other causes include protozoal infections like Giardia, which can damage the mucosa, numerous medications, olmesartan again, mycophenolate, colchicine, clostramine, neomycin, idiopathic enteropathies, amyloidosis infiltrating the gut wall, and chronic intestinal ischemia reducing blood flow to the absorptive cells.
And the third category was post-mucosal lymphatic obstruction, after absorption.
Exactly. This is rare. After fat is absorbed into the intestinal cells, it's packaged into particles called chylomicrons, which are then transported away from the gut via the lymphatic system, not the blood vessels directly. Obstruction of these intestinal lymphatics either congenitally, called intestinal lymphedectasia, or acquired due to trauma, tumor blocking the lymphatics, severe cardiac failure causing high lymphatic pressure, or infection impairs this fat transport out of the gut wall.
What does that look like clinically?
It creates a unique constellation of findings. Fat malabsorption plus significant enteric protein loss, because protein-rich lymph fluid leaks back into the gut, leading to low albumin and edema, and lymphocytopenia, low white blood cell count because lymphocytes also travel via lymph. Interestingly, absorption of carbohydrates and amino acids, which travel via the blood, is usually preserved.
Okay, fascinating. Let's move to inflammatory causes. Here, the gut lining is actually inflamed, leading to dysfunction.
Right. Inflammatory diarrheas are generally accompanied by other signs of inflammation, typically abdominal pain, maybe fever, or bleeding. The diarrhea itself is caused partly by exudation of fluid, mucus, and protein from the inflamed leaky mucosa. But the inflammation also disrupts normal absorption and can induce hypersecretion and hypermotility through the release of inflammatory mediators like cytokines.
How do you know it's inflammatory?
A key finding on stool analysis suggestive of inflammation is the presence of fecal leukocytes, white blood cells, or, more reliably, elevated levels of leukocyte-derived proteins, like fecal calprotectin or lactoferrin. Severe intestinal inflammation can cause significant protein loss into the gut lumen, leading to severe hypoalbuminemia and generalized edema, sometimes called anosarca.
And the source highlights a critical alert here regarding inflammatory diarrhea, especially in older adults.
This is a really important, potentially life-saving point. Any middle-aged or older person presenting with chronic inflammatory type diarrhea, especially if it's bloody, must be carefully evaluated to exclude a colorectal tumor. Colon cancer can absolutely present with chronic diarrhea and bleeding, and it's essential not to miss it by assuming it's just inflammation.
What are the specific inflammatory causes to consider?
Idiopathic inflammatory bowel disease, IBD, meaning Crohn's disease, and chronic ulcerative colitis are common organic causes of chronic inflammatory diarrhea in adults. They vary widely in severity and can have numerous extraintestinal manifestations affecting the eyes, uveitis, joints, polyarthralgias, liver, primary sclerosing cholangitis PSC, and skin, erythema nodosum, pyoderma gangrenosum.
Microscopic colitis is another one mentioned.
Yes, microscopic colitis, which includes lymphocytic and collagenous colitis, is increasingly recognized, particularly in middle-aged women, causing chronic watery diarrhea. Crucially, the colon often looks completely normal on endoscopy, meaning you must take biopsies to make the diagnosis. It's been linked to various medications, including NSAIDs, statins, PPIs, and SSRIs. It can also coexist with IBS symptoms, functional diarrhea, celiac sprue, or drug-induced enteropathy. Fortunately, it often responds well to treatments like bismuth, loperamide, or the steroid budesonide.
Immunodeficiency can also lead to chronic inflammatory issues, not just infections.
That's right. Primary or secondary immunodeficiency can result in prolonged infectious diarrhea due to impaired clearance of pathogens, but it can also make patients susceptible to chronic inflammatory enteropathies. Selective IgA deficiency and common variable immunodeficiency, CVID, are particularly associated with an increased prevalence of giardiasis, bacterial overgrowth, and a sprue-like enteropathy that has inflammatory features.
Eosinophilic gastroenteritis is another one listed. Sounds allergic.
It involves infiltration of eosinophils, a type of white blood cell, often associated with allergies, into various layers of the GI tract. This can cause symptoms like diarrhea, pain, vomiting, or even ascites, fluid in the abdomen. Patients often have a history of atopy, allergies, asthma, eczema. Charcot-laden crystals, which are breakdown products from eosinophils, can sometimes be found in the stool. And peripheral eosinophilia, high eosinophil count in the blood, is present in 50-75% of patients. However, the source notes that true food allergy is actually a rare cause of chronic diarrhea in adults, unlike its role in infants.
Any other inflammatory causes?
Yes, radiation enterocolitis, which can develop months or years after radiation therapy to the abdomen or pelvis. Chronic graft versus host disease in transplant recipients. Autoimmune enteropathy, a rare condition where the body's immune system attacks its own gut lining. Chemotherapy can cause inflammatory diarrhea, and there are specific chemotherapy-induced diarrhea syndromes.
Okay, next category. Dysmotility causes. Problems with how the gut moves content.
Right. While rapid transit can certainly contribute to diarrhea caused by other mechanisms, like secretory or osmotic, primary dysmotility as the sole cause of true chronic diarrhea is relatively unusual. When it does occur, the stool features often resemble secretory diarrhea, watery, maybe large volume. Mild steatorrhea, up to 14 GD, can sometimes occur simply due to rapid transit not allowing enough time for complete digestion and absorption.
What conditions cause this rapid transit?
Conditions associated with generalized hypermotility include hyperthyroidism, carcinoid syndrome due to serotonin and other mediators, and certain drugs such as prostaglandins or prokinetic agents designed to speed up gut transit.
What about conditions that cause slow motility, like pseudo-obstruction? Can that cause diarrhea?
Paradoxically, yes. Primary visceral neuromyopathies, or idiopathic acquired intestinal pseudo-obstruction conditions, where the gut muscle or nerves don't work properly, leading to severely slowed transit, can cause profound stasis. This stasis, in turn, often leads to secondary bacterial overgrowth in the small intestine, which can then cause diarrhea via maldigestion of fats and carbohydrates, as we discussed under steatorrhea. So slow gut causes bacterial overgrowth, which causes diarrhea.
Complicated. And diabetic diarrhea.
Diabetic diarrhea, often seen in patients with long-standing diabetes who also have peripheral and generalized autonomic neuropathies, is thought to involve a component of dysmotility, among other potential mechanisms like bacterial overgrowth or altered secretion.
And irritable bowel syndrome, IBS, is categorized here under dysmotility.
Yes. IBS is considered a classic functional bowel disorder, affecting maybe 10% of the population at any given time. It's characterized by disturbed intestinal and colonic motor and sensory responses to various stimuli. While IBS can present with constipation or alternating patterns, IBS with diarrhea, IBSD, is very common. Key symptoms that help distinguish IBSD from many organic causes of chronic diarrhea include the fact that the diarrhea typically stops at night. It often alternates with periods of constipation or normal bowel function. It's usually accompanied by abdominal pain that is characteristically relieved by defecation, and importantly, it rarely causes significant weight loss, which is a major red flag for organic disease.
Factitious causes are those that are self-induced, often covertly. This must be difficult to diagnose.
It's a very challenging category, but surprisingly common in specialized referral centers, accounting for up to 15% of unexplained chronic diarrheas. It involves patients intentionally causing their own symptoms, sometimes as a manifestation of Munchausen syndrome, where people feign illness for attention or other psychological gain or linked to eating disorders. They might covertly self-administer laxatives, sometimes combined with diuretics to enhance fluid loss, or even add water or urine to stool samples they provide to mimic diarrhea.
Are there typical characteristics or clues for these patients?
The profile described is typically women, often with a documented or suspected history of psychiatric issues, and interestingly, a disproportionate number work in healthcare careers, which might give them access to medications and knowledge of how to manipulate samples or symptoms. Clues on physical exam or routine labs can include unexplained hypotension, low blood pressure, and hypokalemia, low potassium, which are common side effects of laxative or diuretic abuse. Evaluation is difficult because patients usually deny it vehemently. Stool osmolarity testing can provide clues very low if water has been added, very high if urine has been added. The source stresses that these patients often benefit greatly from psychiatric counseling, but usually only when they are able to acknowledge their behavior.
And finally, iatrogenic causes related to medical treatment or procedures.
Right. Certain surgical procedures can permanently alter gut function and lead to chronic diarrhea. Cholecystectomy, gallbladder removal, can sometimes lead to bile acid diarrhea due to changes in the bile acid pool size and how bile is delivered to the gut. Significant ileal resection, as we discussed, reduces the surface area for bile acid and fluid absorption. Bariatric surgery, weight loss surgery procedures can alter transit times and absorption patterns. Phlebotomy, cutting the vagus nerve, sometimes done for ulcers in the past, and fundoplication, wrapping the stomach around the esophagus for reflux, can also alter gut motility and function, sometimes resulting in diarrhea.
Okay, with that vast, almost overwhelming list of potential causes for chronic diarrhea, how do you possibly approach the patient? The source provides an algorithm, figure 46-4, to help structure this.
This is where the systematic approach is absolutely critical, because the evaluation tools available are extensive, many are costly, and some are invasive. The workup must be rationally directed, starting with a meticulous history and physical examination. A detailed history, including a comprehensive review of all medications, prescription, OTC, supplements, herbals, diet, including potential triggers like dairy, gluten, FODMAPs, travel, exposures, and family history, is paramount. Table 46-4 in the source details key points to look for in the physical exam, aiming to identify clues pointing to systemic disease or specific underlying mechanisms.
So history and physical are really the initial triage.
Absolutely. They allow you to characterize the diarrhea's pattern. Is it watery, fatty, bloody? Its duration, frequency, timing, day versus night, and associated symptoms, pain, weight loss, fever, and identify any extraintestinal manifestations like rashes or joint pain, or risk factors that point towards a specific mechanism or diagnosis. Based on this initial assessment, routine blood tests are typically performed to check for inflammation, WBC count, ESR, CRP, anemia suggesting blood loss or nutrient deficiency, electrolyte abnormalities, common in secretory diarrhea, and markers of malabsorption or systemic disease, albumin, liver function tests, thyroid function, calcium, potassium.
What are the key points in the history from table 46-4 that are most revealing? What should you really focus on asking?
Onset, duration, and pattern are critical. Does it wake them from sleep? Suggests organic cause, less likely IBS. Does it stop completely with fasting? Strongly suggests osmotic. Does it worsen with fatty foods? Points to steatorrhea. Are there associated symptoms like fever or bleeding? Points to inflammatory. Weight loss is a major red flag for malabsorption or serious organic disease like cancer, IBD, or severe infection. Pain relieved by defecation is classic for IBS. Dietary history is essential, asking specifically about dairy, artificial sweeteners, high fructose corn syrup, recent changes. Medication review, as we said, is non-negotiable. Travel, sick contacts, or recent antibiotic exposure point towards infectious or post-infectious causes. Extraintestinal symptoms like joint pain, skin rashes like dermatitis herpetiformis for celiac, or oral ulcers can indicate IBD or celiac disease. And family history is important for IBD and celiac disease.
And on physical exam, what are you looking for?
Table 46-4 reminds us to look for general signs of malabsorption pallor from anemia. That's specific rash dermatitis herpetiformis for celiac, edema from protein loss, finger clubbing, signs of autonomic neuropathy or collagen vascular disease, pupil abnormalities, orthostatic hypotension, dizziness on standing, skin changes like scleroderma, hand deformities, joint inflammation. The abdominal exam looks for masses or localized tenderness. A thorough rectal exam is vital to assess the mucosa, rule out structural defects or masses, and evaluate sphincter tone and function. And looking for those mucocutaneous signs of systemic illness like dermatitis herpetiformis, erythema nodosum, often with UC, flushing carcinoid, or oral ulcers, IBD, celiac.
Specific blood tests can be helpful early on. You mentioned celiac.
Yes, especially serologic tests for celiac disease, such as IgA tissue transglutaminase antibodies, which are highly sensitive and specific screening tests and relatively easy to obtain. For suspected bile acid diarrhea, BAD, while the gold standard diagnostic test is a scintigraphic bile acid retention test using something called SAGE-CAT, it's unfortunately not widely available in many places. So alternatives mentioned are screening blood tests like serum C4 or FGF19 levels, directly measuring fecal bile acids, also not widely available, or, very practically, pursuing a therapeutic trial with a bile acid sequestrant like cholestyramine, cholestyramine, or cholecalciferol.
A therapeutic trial seems like a practical step if suspicion is high for something treatable.
The source definitely notes that a therapeutic trial is often appropriate, can be cost-effective, and sometimes is diagnostic in itself, particularly when the initial history and physical strongly suggest a specific diagnosis. For example, if a young adult has watery diarrhea that clearly stops with fasting and gets much worse with dairy, a trial of a strict lactose-restricted diet is a very reasonable first step. If diarrhea follows a backpacking trip and has features suggestive of giardiasis, a trial of metronidazole could be considered. Postprandial diarrhea after an ileal resection strongly suggests bile acid malabsorption, so a trial of a bile acid sequestrant makes sense. If symptoms persist despite a well-conducted trial, then further investigation is warranted.
What if the initial workup, including basic labs and perhaps celiac serology, is unrevealing, but the pattern really sounds like IBS?
If IBS is strongly suspected based on the typical symptom pattern, pain related to defecation, change in stool form frequency, absence of red flags like weight loss or bleeding, and symptoms often stopping at night, the initial evaluation often includes flexible sigmoidoscopy with colorectal biopsies. This is primarily done to rule out conditions that can mimic IBS, particularly microscopic colitis or subtle IBD. If these findings are normal, then reassurance is appropriate, and empirical treatment targeting IBS symptoms, like antispasmodics for pain, antidiarrheals for frequent urgency, or sometimes low-dose tricyclic antidepressants which can help both pain and diarrhea, can be initiated.
What if chronic diarrhea is accompanied by hematochezia, visible blood in the stool?
Any chronic diarrhea with gross blood requires urgent and thorough investigation. This mandates stool microbiologic studies to rule out persistent infectious causes like C. diff, amoeba, Shigella, and crucially, colonoscopy to exclude inflammatory bowel disease, or, most importantly, given the bleeding, colorectal cancer. You cannot ignore chronic bloody diarrhea.
What if the cause is still unclear after this initial assessment? The source says this happens in about 2/3 of cases referred to specialists. That's a lot.
It is. Then you move to more objective measures. Quantitative stool collection and analysis are the next logical step and serve as a crucial triage tool, as shown clearly in FES 46-4. The patient collects all stool over a 24 or 72-hour period, and the total weight is measured. If the stool weight is confirmed to be greater than 200 grams per day, confirming true diarrhea, then further analyses of the collected stool are performed.
What kind of analyses?
These typically include measuring electrolyte concentrations, sodium and potassium to calculate the osmotic gap, stool pH, testing for occult hidden blood, microscopic inspection for leukocytes, or quantitative assays for leukocyte-derived proteins like calprotectin or lactoferrin to objectively assess for inflammation, quantitative fat measurement, the definitive test for steatorrhea, and screening for laxatives, especially if factitial diarrhea is suspected.
And then you direct further evaluation based on those findings, like is it watery, fatty, or inflammatory?
Exactly. The results of the quantitative stool studies help narrow down the likely pathophysiologic mechanism, guiding the next phase of investigation much more effectively. For example, if it points to secretory diarrhea, watery normal osmotic gap persists with fasting, you circle back and reevaluate medications very carefully and screen for surreptitious laxatives again. Microbiologic studies are done if not already, maybe including cultures for less common pathogens like Aeromonas and Plesiomonas, thorough O&P exams, and Giardia antigen tests, often more sensitive than microscopy. Small bowel bacterial overgrowth needs exclusion, perhaps using duodenal aspirate cultures obtained during endoscopy or non-invasively with glucosylactulose breath tests, though interpretation can be tricky if transit is altered. Upper endoscopy and colonoscopy with biopsies are performed to look for subtle inflammatory or microscopic causes. Small bowel imaging, using barium X-rays, CT enterography, or MinR enteroclysis, is used to rule out structural lesions, fistulas, or subtle inflammatory disease not seen on endoscopy. And only if symptoms or history strongly suggest. Hormone screens, serum gastrin, VIP, calcitonin, thyroid hormones, urinary 5-HIA for carcinoid, plasma, or urinary histometabolites for mastocytosis are performed. If it points to osmotic diarrhea, stops with fasting, has an osmotic cap, you specifically test for lactose intolerance, usually with the breath test or with the therapeutic trial we mentioned, and look carefully for ingestion of magnesium or other osmotic agents, like sorbitol and sugar-free products. Low fecal pH is also a clue towards carbohydrate malabsorption. If fecal magnesium or specific laxative levels are elevated, inadvertent or surreptitious ingestion is confirmed, and psychiatric evaluation and counseling should be gently pursued. If steatorrhea is confirmed, more than 7G FAD, endoscopy with small bowel biopsy is usually the next step, often including aspiration of duodenal fluid for cultures to check for bacterial overgrowth or Giardia. If the biopsy is unrevealing, small bowel imaging, X-ray, CTMR, is done to look for structural causes of stasis, like strictures diverticula or mucosal disease. If pancreatic disease is suspected based on history, like chronic pancreatitis risk factors or imaging, specific tests for pancreatic exocrine insufficiency are performed. Direct tests, like the secretion and CCK stimulation test done via endoscopy, are more sensitive but invasive and complex. Indirect tests, like fecal elastase or fecal chymotrypsin levels, are less sensitive but much easier to perform on a stool sample. If inflammatory diarrhea is indicated, blood or leukocyte calprotectin in stool, stool cultures, O&P and C difficile toxin assays are essential to rule out infection. Colonoscopy with biopsies is mandatory to look for IBD, microscopic colitis, infection, ischemia, or cancer. Small bowel imaging may be needed as well if Crohn's disease involving the small bowel is suspected.
That systematic approach, really guided by the stool analysis, is clearly key to avoiding just ordering a scattershot of expensive tests and honing in on the actual diagnosis.
It absolutely is. It's the difference between flailing around and applying rational diagnostic steps based on the underlying physiology.
Finally, let's talk about treatment for chronic diarrhea. This obviously depends heavily on the specific diagnosis you eventually reach.
Exactly. Treatment really falls into three broad categories: curative, suppressive, or empirical symptomatic. Curative treatment means eradicating the underlying cause if you can. Examples would be surgical resection of a tumor causing obstruction or hormone secretion, antibiotics for specific infections like Whipple's disease or tropical sprue, or simply discontinuing a medication identified as the culprit.
What about suppressive treatment?
Suppressive treatment aims to control the underlying pathophysiologic mechanism when the cause cannot be cured or fully eliminated. This includes things like dietary modifications, strict lactose, or gluten exclusion for malabsorption syndromes, using glucocorticoids or other anti-inflammatory immunosuppressive agents for IBD, using bile acid sequestrants for bile acid diarrhea, proton pump inhibitors, PPIs, to dramatically reduce acid secretion in gastronoma, somatostatin analogs like octreotide for hormone-secreting tumors like malignant carcinoid or vivipoma, prostaglandin inhibitors for diarrheas mediated by prostaglandins, for example, from medullary thyroid CA or Vill's adenoma, or pancreatic enzyme replacement therapy for pancreatic insufficiency.
And what about empirical treatment when the cause isn't entirely clear or specific treatments aren't working well enough? Treating the symptoms.
Yes. If the cause remains unclear despite thorough investigation, or if specific treatment isn't fully effective, symptomatic empirical treatment can be used to improve quality of life. Mild opiate-based agents like loperamide, which slows transit and has some anti-secretory effects, or diphenoxylate, often combined with atropine, can be effective for mild to moderate watery diarrhea. For more severe cases, stronger agents like codeine or even tincture of opium might be considered cautiously.
But there's a caution with those anti-motility agents.
Yes, a very important one. Anti-motility agents should generally be avoided in patients with active severe inflammatory bowel disease, especially ulcerative colitis, due to the risk of precipitating toxic megacolon, which is a life-threatening dilation and paralysis of the colon.
Are there other specific agents used symptomatically for certain types of chronic diarrhea?
Yes. Clonidine, an alpha-2 adrenergic agonist, can sometimes be effective for diabetic diarrhea, although postural hypotension, dizziness on standing, can be a limiting side effect.
Ooh.
For the diarrhea and urgency component of IBSD, 5-HT3 receptor antagonists like allosterone can be used, but only in carefully selected female patients due to a rare but serious risk of ischemic colitis, so its use is restricted.
Any newer options for IBSD?
Yes, other approved medications for IBSD include rifaximin, which is a non-absorbed antibiotic thought to modulate the gut microbiome and perhaps reduce symptoms related to bacterial fermentation or overgrowth, and alloxylene, which acts on opioid receptors in the gut, mu agonist, kappa agonist, delta antagonist. However, alloxylene carries a risk of sphincter of otispasm and acute pancreatitis, particularly in patients who have had their gallbladder removed post-cholecystectomy, so its use requires careful patient selection and counseling.
Beyond medications, what supportive measures are important?
Fluid and electrolyte repletion remain important, especially in cases of significant secretory diarrhea, to prevent dehydration and its consequences. For patients with chronic steatorrhea leading to malabsorption of fat-soluble vitamins, replacement of vitamins A, D, E, and K is necessary to prevent deficiency-related complications like night blindness, bone disease, neurological issues, or bleeding problems.
Okay, that's a very thorough exploration of diarrhea in all its forms. Now, let's transition to the other side of the spectrum, constipation. The source defines this as persistent, difficult, infrequent, or seemingly incomplete defecation. Sounds like it can mean different things to different people.
It absolutely can. And the source rightly notes that defining it precisely can be tricky, because what's normal, bowel frequency, varies widely among individuals. Simply having infrequent bowel movements, say, less than the commonly cited 3 per minute, isn't enough on its own for a diagnosis of constipation. Patients often report other symptoms that are actually more defining for them. Excessive straining during bowel movements, passing hard or pellety stools, like using the Bristol Stool Form Scale types 1 or 2, feeling a sense of lower abdominal fullness or bloating, or the sensation of incomplete evacuation after going. It's crucial to analyze their specific symptoms in detail, not just focus on frequency.
Stool consistency seems like an important objective indicator of transit time.
It is a very good correlate. Hard pellety stools, Bristol type 1, strongly suggest slow transit through the colon. Conversely, loose or watery stools, Bristol types 6 or 7, indicate rapid transit. Both very small, pellety stools and very large, hard stools can be difficult to expel for mechanical reasons. While the perception of hard stools as straining can be subjective, objective signs like the reported need for manual maneuvers using enemas, suppositories regularly, or even digital disimpaction are strong indicators corroborating the patient's description of difficult defecation.
And psychosocial or cultural factors can influence the perception and management of constipation.
Absolutely. The emphasis placed on having a daily bowel movement in some cultures can lead to undue anxiety or overuse of laxatives when it might not be physiologically necessary. Stool withholding, often seen in children due to fear of pain from a previous hard stool or sometimes as a behavioral control mechanism, can contribute to chronic issues like rectal dilation and decreased sensation. And habitually ignoring or delaying the urge to defecate in adults because it's inconvenient can, over time, diminish rectal sensitivity and contribute to constipation and difficulty evacuating.
What's the underlying pathophysiology of chronic constipation? What's actually going wrong?
Generally, the source suggests it results from inadequate dietary fiber and fluid intake, which affects stool bulk and consistency, making it harder to pass, or from disordered colonic transit, things moving too slowly, or anorectal function, problems with the exit mechanism. These issues themselves can stem from underlying neurogastroenterologic disturbances affecting the gut muscle or nerves, side effects of medications, opiates are a huge one, but many others too, age-related changes, or various systemic diseases. Table 46-5 in the source provides a long list, including things like hypothyroidism, hypercalcemia, Parkinson's disease, multiple sclerosis, scleroderma.
Is recent onset constipation a cause for concern, like with diarrhea?
Yes, definitely. Just like with diarrhea, new onset constipation, particularly in older adults or someone with previously regular habits, can be a red flag signaling a potentially significant organic disease. It could be a colorectal tumor partially obstructing the lumen, anorectal irritation, like a fissure making defecation painful, or a stricture from prior diverticulitis or ischemia. This warrants prompt structural investigation. In cases of idiopathic chronic constipation, meaning where no specific underlying disease is found after evaluation, a subset of patients have defined motility abnormalities. Some have specifically delayed emptying of the ascending and transverse colon, those main reservoir segments. Others seem to have prolonged transit throughout the proximal colon, characterized by a reduced frequency of those high-amplitude propagated contractions, HAPCs, that normally drive mass movements.
What about problems with the final act of elimination, getting it out?
Right. Outlet obstruction to defecation, also known as evacuation disorders or pelvic floor dysfunction, is very common, accounting for about a quarter of patients seen in specialized tertiary care settings for severe constipation. These disorders involve dysfunction of the pelvic floor muscles, like the puborectalis, or the anal sphincters that impede the expulsion of stool, even if the stool reaches the rectum normally.
Can that cause slow transit too?
Interestingly, yes. These evacuation disorders can themselves cause secondary delayed colonic transit, because the inability to effectively empty the rectum leads to a backup of stool higher up in the colon. However, this secondary delayed transit often improves significantly once the underlying evacuation disorder is successfully treated, typically with specialized physical therapy involving biofeedback retraining.
And external factors can exacerbate constipation, make it worse.
Oh, definitely. Factors like hospitalization, chronic illness leading to reduced mobility, or prolonged bed rest often lead to decreased physical activity, changes in diet and routine, and sometimes dehydration, all of which can worsen pre-existing constipation or precipitate new onset constipation in vulnerable individuals.
So how do you approach a patient presenting with constipation? The source provides another helpful algorithm. Figure 46-5.
The evaluation, again, starts with a thorough history and physical examination. The history needs to be very specific. Exactly what does the patient mean by constipation? Frequency, consistency, using something like the Bristol School Form Scale, the amount and duration of straining, the time spent attempting to defecate, and crucially, asking directly about the need for any manual maneuvers like pressing on the perineum or vaginal wall or digitally extracting stool. These latter points are strong clues pointing towards a possible evacuation disorder rather than just slow colonic transit alone.
But in the vast majority of cases presenting to primary care, the cause is straightforward.
Yes. The source suggests over 90% of patients have no serious underlying cause found. Their constipation is typically functional and responds well to simple lifestyle measures, increasing hydration, increasing physical exercise, and significantly increasing dietary fiber intake, aiming for maybe 15 to 25 grams per day. A detailed dietary history, are they eating enough fiber, and medication history, are they on constipating drugs, are essential in these cases, as is exploring potential psychosocial factors.
The physical and rectal exam are mandatory, no skipping that.
Absolutely non-negotiable. The general physical exam can reveal signs of systemic disease, like thyroid issues, or the consequences of chronic straining, like hemorrhoids. The rectal exam is crucial. It allows you to check for fecal impaction, a common cause of overflow incontinence or worsening constipation. Rule out structural abnormalities in the rectum or anus, like strictures, masses, fissures that cause pain. Assess anal sphincter tone at rest and with voluntary squeeze. And importantly, look for those signs suggestive of an evacuation disorder.
How do you check for that on exam?
During a simulated defecation effort, asking the patient to bear down as if having a bowel movement, you observe if the perineum descends normally, it should move down 1 to 3.5 centimeters, and you feel for paradoxical contraction or tenderness of the puborectalis muscle sling, it should relax and move posteriorly, not tighten and move anteriorly.
When is it necessary to investigate for structural disease? Colonoscopy or imaging?
If there are red flag symptoms or signs in the history or physical exam, things like recent onset constipation in an older adult, unexplained weight loss, rectal bleeding or anemia, especially patients over 40 or 50, investigation to exclude a structural cause like a colorectal tumor or a significant stricture is mandatory.
How is that usually done?
This is typically done with either a flexible sigmoidoscopy combined with a barium enema X-ray or a full colonoscopy. Colonoscopy has the advantage of allowing direct visualization of the entire colon, biopsy of suspicious lesions, removal of polyps, and sometimes dilation of strictures, making it often considered more comprehensive and potentially cost-effective overall. However, the source notes that barium enema can sometimes be advantageous for evaluating isolated constipation as it's less costly and can be particularly good at visualizing the overall size and shape of the colon, identifying diffuse dilation, megacolon, long strictures, or signs of cathartic colon from chronic stimulant laxative abuse, loss of hostra. Melanosis coli, that dark pigmentation of the colon lining indicating past anthraquinone laxative use, like senna, might be seen on either study.
And screening for metabolic causes?
Yes, simple screening serum tests for calcium, looking for hypercalcemia, potassium, hypokalemia can worsen constipation, and TSH, thyroid-stimulating hormone, for hypothyroidism are important to rule out these common metabolic contributors.
If there are no red flags and basic labs are normal, what's the initial management strategy beyond fiber?
If increasing fiber and fluids isn't sufficient on its own, the source recommends a bowel training regimen. This often involves incorporating a regular osmotic laxative, like polyethylene glycol or lactulose, to ensure softer, easier to pass stools and perhaps using enemas or suppositories as needed initially to help establish regularity. A key part of the training is establishing a regular time each day, often 15-20 minutes after breakfast, to take advantage of the natural gastrocolic reflex, to sit on the toilet in a relaxed environment, perhaps with feet elevated on a stool, and attempt a bowel movement without excessive straining.
Straining seems like something to really advise patients against long-term.
It absolutely is. While some effort is normal, excessive chronic straining can lead to or worsen hemorrhoids. Over years, it can also contribute to pelvic floor weakness or potentially cause stretch injury to the pudendal nerve, which controls the external sphincter and pelvic floor sensation. This can paradoxically lead to problems later in life, including fecal incontinence or worsened obstructed defecation from something called descending perineum syndrome.
For the minority who don't respond to these simple measures or require long-term treatment, maybe using potent laxatives but still struggling, further investigation is needed.
Exactly. This is where you start considering the possibility of a more significant functional bowel disorder, like slow transit constipation or an evacuation disorder, and proceed with more detailed physiological testing, as outlined in Figure 46-5. This small percentage of patients needs a more in-depth workup. The source also notes that newer secretory agents lubiprostone, linaclotide, plecanatide, and tenofovir are available prescription options for symptomatic treatment in these patients with chronic idiopathic constipation who haven't responded adequately to other measures.
For severe or truly intractable constipation, a specialist evaluation is often warranted.
Yes, this is a small group, likely less than 5% of patients with constipation overall, but these are the really complex and challenging cases. As noted, about a quarter of patients referred to tertiary centers for severe constipation actually have underlying evacuation disorders. The specialist evaluation aims to definitively rule out less common causes, subtle dietary issues, confirm a primary motility disorder, exclude covert laxative abuse or malingering, and assess for significant contributing psychological disorders. The evaluation focuses on objectively assessing the physiologic function of the colon and the pelvic floor anorectal unit, alongside psychological status. It's important to note, however, that even in these highly selected patients referred to specialists, a specific underlying physiologic cause is only clearly identified in about a third. Many others fall into the category of normal transit constipation, despite having severe, debilitating symptoms.
Should tests for anorectal function happen before tests for colonic transit? Does the order matter?
The source generally recommends performing anorectal and pelvic floor testing first if there are specific symptoms suggestive of an evacuation disorder, like straining, incomplete emptying, need for maneuvers. This is because, as we mentioned, a significant evacuation disorder can secondarily slow down colonic transit. If a primary evacuation disorder is found and successfully treated, the colonic transit delay may resolve, potentially making a separate transit study unnecessary.
How is colonic transit measured objectively? How do you time it?
The most common methods involve radiopaque markers. These are small, inert, plastic rings or sheets that the patient swallows, usually in a capsule. They are easy to use, reliable, relatively safe, and inexpensive. Several protocols exist. One common one involves swallowing a capsule of 24 markers and taking a single abdominal X-ray 5 days, 120 hours later. Normally, at least 80%, so 5 or fewer markers remaining, should have passed out of the colon. Another method involves swallowing 10 markers each day for 3 consecutive days and taking an X-ray on day 4. The number and location of markers retained can be used to estimate transit time through different segments of the colon, right, left, rectosigmoid.
What do these marker studies tell you?
They specifically assess colonic transit, but don't evaluate stomach or small bowel motility. A finding of markers scattered throughout the colon suggests slow transit constipation, while markers predominantly clustered in the rectum or sigmoid suggest a possible evacuation disorder or outlet delay. A more advanced but less commonly available method is radioscintigraphy. Here, radiolabeled particles are delivered to the colon via a special delayed-release capsule. This allows simultaneous assessment of gastric emptying, small bowel transit, and colonic transit over 24-48 hours. This can be important as about 20% of patients with proven delayed colonic transit also have generalized upper GI dysmotility. Disadvantages are the cost and the need for specialized nuclear medicine facilities.
Anorectal and pelvic floor tests sound particularly important for those suspected evacuation disorders. What do they involve?
They are key. Symptoms like the inability to completely evacuate despite prolonged effort, persistent rectal fullness or pain after attempting a bowel movement, needing to use digital extraction, or needing to apply pressure to the perineum or vaginal wall during straining are strong indicators of possible pelvic floor dysfunction. These need to be distinguished from the more subjective feeling of incomplete evacuation that is common in IBS.
Psychological factors were mentioned. Is formal evaluation common in this setting?
Yes, for patients with severe intractable constipation, especially if an evacuation disorder is suspected or if symptoms seem disproportionate to objective findings, a formal psychological evaluation can be very helpful. It can identify contributing factors like eating disorders, significant anxiety or depression, history of trauma, PTSD, or specific control issues related to defecation. Addressing these underlying psychological factors can significantly improve symptoms and overall quality of life, even if they aren't the sole physiological cause of the constipation.
What about those simple clinical tests for pelvic floor function you can do in the office?
As mentioned, the digital rectal exam during simulated straining is key. You feel the puborectalis muscle. In proper coordination, it should relax and the angle should straighten, allowing it to move posteriorly. Finding paradoxical contraction, where it tightens and moves anteriorly, or observing limited perineal descent, less than 1.5 centimeters during straining, suggests dysfunction. Perineal descent can also be roughly measured clinically with a ruler while the patient is lying in the left decubitus position and straining. Excessive descent, more than 4 centimeters ballooning, can also be abnormal descending perineum syndrome.
The balloon expulsion test seems like a basic functional screen for the exit pathway.
It's considered an important and relatively simple screening test for anorectal evacuation function. A small balloon catheter is inserted into the rectum and filled with about 50 milliliters of water. The patient is then asked to try and expel the balloon while seated on a commode or sometimes in the left lateral position. A normal result is typically defined as being able to expel the balloon, usually unaided, within about 1 minute. Difficulty or inability to expel the balloon strongly suggests an evacuation disorder.
Anorectal manometry provides more detailed pressure measurements. What does that show?
Yes, this is a key specialized test in the evaluation of severe constipation and suspected evacuation disorders. It uses a pressure-sensitive catheter to measure pressures in the anal sphincters at rest and during voluntary squeeze, and critically, during simulated straining or relaxation. It also evaluates rectal sensation. When does the patient first feel stool? And compliance. How much the rectum can stretch. Abnormal findings suggestive of constipation or dysfunction can include abnormally high resting or squeeze pressures, impaired relaxation, or even paradoxical contraction of the external anal sphincter and/or puborectalis muscle during simulated straining, or abnormalities in rectal sensation. Hyposensitivity is common.
Does it help diagnose specific conditions?
A crucial finding it can detect is the absence of the rectoanal inhibitory reflex, RAIR. This is a normal reflex relaxation of the internal anal sphincter in response to rectal distension. Its absence is the hallmark finding for Hirschsprung's disease, a congenital condition causing constipation, usually diagnosed in childhood, but occasionally presenting in adulthood.
Defecography, or dynamic imaging using X-ray or MRI, gives a visual picture of the process.
Exactly. Defecography, using either a dynamic barium paste rectogram, like a video X-ray, or increasingly MR defecography, provides a dynamic image of the pelvic floor and rectum during the act of simulated defecation. It can reveal what the source calls soft abnormalities, like how much the rectoanal angle changes during straining, or identify anatomic defects such as internal mucosal prolapse and a racele, herniation of small bowel down towards the rectum, or rectocele, bulging of the rectum, usually anteriorly into the vagina.
Are these findings definitive?
Not always. The source notes that truly surgically remediable lesions, like a severe full-thickness rectal intussusception causing complete blockage or an extremely large symptomatic rectosole, are identified in only a few patients. An experienced radiologist is needed to interpret these studies, as some degree of rectocele or minor prolapse can be seen even in asymptomatic individuals and may not be the primary cause of symptoms. While traditional barium defecography shows structural changes well, MR defecography is often preferred now as it provides better soft tissue detail, more information about pelvic floor, muscle anatomy and movement, and can directly visualize failure of puborectalis relaxation during straining, which barium cannot.
And finally, neurologic testing. Does that play a role?
Electromyography, EMG, of the pelvic floor muscles is used more often in evaluating fecal incontinence than obstructed defecation. But it can sometimes provide information, particularly looking for evidence of nerve damage, denervation. Finding denervation without obvious lower extremity neurologic signs might suggest nerve damage related to prior pelvic or obstetric injury, or potentially chronic pudendal nerve stretch from long-term straining. Constipation is also very common in generalized neurologic conditions like spinal cord injury, Parkinson's disease, multiple sclerosis, and diabetic neuropathy, so the standard neurological exam looking for signs of these is important context. Spinal evoked responses can assess the integrity of sensory nerve pathways, which is sometimes relevant when considering suitability for biofeedback therapy.
So for severe cases, it's a stepwise investigation, starting with screening tests like balloon expulsion and then focusing on more detailed anatomic and physiological tests if an evacuation disorder is suspected based on symptoms.
Exactly. Balloon expulsion is a good initial functional screen. Formal anatomic imaging, like defecography, and physiological tests of pelvic floor relaxation, like manometry or EMG, are typically reserved for patients with suspected obstructed defecation based on specific symptoms like straining and incomplete emptying.
Finally, treatment for constipation. This clearly depends heavily on the cause identified through that evaluation process.
It absolutely does, as summarized back in Figure 46-5. If slow transit constipation is definitively identified and is severe, it often requires aggressive medical management, and in very rare selected cases, potentially surgery. For patients whose primary problem is anismus, failure of the puborectalis to relax, or other forms of pelvic floor dysfunction causing evacuation disorders, biofeedback training is the cornerstone of treatment and is often highly effective, with success rates frequently cited in the 70-80% range. Older operations designed to surgically cut the sphincter or puborectalis muscle, or injections of botulinum toxin into the muscle, have generally shown mediocre long-term success and are largely abandoned now in favor of retraining the muscles.
For the largest group, those with intractable symptoms but found to have normal transit constipation on testing, what's the approach?
They are primarily treated symptomatically, often requiring ongoing use of the lifestyle measures, high fiber, fluids, exercise, and various laxatives we discussed earlier. Finding the right combination and dosage often involves trial and error. For patients with constipation clearly due to underlying specific neurologic disorders like spinal cord injury or advanced Parkinson's, A dedicated structured bowel regimen is often necessary, which might involve timed use of laxatives, regular rectal stimulation techniques like suppositories or digital stimulation, or scheduled enemas to ensure regular emptying.
The source lists several types of laxatives. Can you recap those categories?
Sure, they broadly fall into these groups: bulk-forming laxatives, like fiber supplements, psyllium, methylcellulose, which absorb water to add bulk and softness to the stool, stimulating contractions; osmotic laxatives, like magnesium salts, used with caution and renal impairment; non-absorbable sugars, lactulose, sorbitol, or polyethylene glycol, PEG 350, often considered first line. These draw water into the colon lumen by osmosis. Secretory agents, or secretagogues, these are newer prescription agents like levetiracetam, a chloride channel activator, linaclotide and plaquenitide, GCC agonists, and tenapanor, an NHE3 inhibitor. They actively stimulate fluid and electrolyte secretion into the lumen. Prokinetic or stimulant laxatives. These directly stimulate gut muscle contractions or nerve activity to promote transit. Examples include bisacidal, sodium picosulfate, common in Europe, and brocalipride, a selective serotonin 5-HT4 receptor agonist. Tegaserod is another 5-HT4 agonist with prokinetic effects, available under restricted use. Stimulants are often effective but sometimes associated with cramping, and long-term daily use is debated, though often necessary for severe cases.
When is surgery actually considered for severe intractable constipation? It sounds like a last resort.
It is absolutely a last resort, reserved for a small minority of patients, and requires a very significant discussion and careful selection. Laparoscopic colectomy with ileorectostomy, which involves removing most of the colon, leaving the rectum, and connecting the small intestine directly to the rectum, can be considered for patients with well-documented, severe, intractable, slow transit constipation.
What are the criteria?
The criteria are very strict. The slow transit must be confirmed by objective testing, like marker studies, and critically, it must be unassociated with a significant obstructed defecation disorder, or the obstruction must be fixed first. The patient must also have failed a substantial trial, maybe 3-6 months, of optimized aggressive medical therapy, including various laxative classes. Crucially, surgery is not indicated for abdominal pain as the primary symptom, and it should never be performed if an evacuation disorder is still present, or if there's evidence of generalized GI dysmotility affecting the stomach or small bowel too. Referral to a specialized motility center for comprehensive testing before even considering surgery is essential. The presence of objective findings like megacolon or megarectum on imaging can sometimes help support the decision for surgery.
What are the outcomes or complications?
Potential complications include small bowel obstruction, adhesions from surgery, persistent diarrhea or high stool frequency, which can be socially debilitating, sometimes 3 to 8 loose stools per day, especially in the first year, incontinence, and potentially recurrent constipation over time. It's a major operation with significant potential downsides.
What if a patient has a combination of issues, like both an evacuation disorder and slow transit? Which do you tackle first?
If a patient clearly has both problems, the standard approach is to address the pelvic floor dysfunction evacuation disorder first. This typically involves pelvic floor retraining with biofeedback, instruction on proper muscle relaxation techniques during defecation, psychological counseling if needed, and optimizing diet and lifestyle factors. Only if symptoms of constipation remain intractable despite successful treatment and resolution of the evacuation disorder and failure of optimized medical therapy for the persistent slow transit component could colectomy with ileorectostomy potentially be considered. But you have to fix the exit problem first.
Wow, we have truly taken a deep dive into diarrhea and constipation today, covering an immense amount of ground from this chapter.
We really have. From the intricate ballet of normal gut physiology, the amazing autonomy of the enteric nervous system, and those precise cellular mechanisms of fluid transport, to the myriad ways things can go wrong, manifesting as either things moving too fast or things moving too slow.
We've looked at acute issues driven largely by infection, spreading through communities, travelers, and specific food sources, and then the complex, often hidden causes of chronic problems that can stem from everything from hormones and genetics to diet, subtle structural issues, inflammation, motility disorders, and even psychological factors.
What really stands out to me from the source material is how much the diagnostic approach, particularly for the chronic issues, relies on you, the listener, taking that meticulous, detailed history to guide a systematic diagnostic process. A process that's really rooted in understanding the underlying pathophysiology. It's not just about treating a symptom, it's about becoming a detective of the gut, trying to pinpoint the specific mechanism that's gone awry.
It really reminds us just how interconnected our bodies are, how the gut's own brain, the enteric nervous system, interacts constantly with the central nervous system, how systemic diseases like thyroid dysfunction or diabetes can manifest primarily with gut symptoms, and how even mental health and things like eating disorders can profoundly influence these fundamental bodily functions. Mastering this really means seeing the whole interconnected picture.
Indeed. Understanding the specific ion channels involved in secretion, the different motor patterns in different gut segments, the hormonal influences from afar, the critical role that pelvic floor coordination, it builds a far clearer and more actionable picture of what's happening than just hearing the word diarrhea or constipation.
So what does this all mean for you, the listener? Perhaps it's a powerful reminder that while these conditions are incredibly common, affecting almost everyone at some point, they are rarely simple when they become chronic or severe. Achieving that elite professional understanding that we aim for requires appreciating this depth and complexity, going beyond the surface complaint to systematically uncover the underlying mechanism. And here's something for you to mull over, building on what we've discussed today. We touched on the critical role of the gut microbiome in normal function, helping digest food, producing nutrients, interacting with motility, and suppressing pathogens. How might the increasing understanding of dysbiosis imbalances in this complex microbial community further weave into the diagnostic and therapeutic strategies for both chronic diarrhea and constipation in the future? It feels like a rapidly evolving area that adds yet another fascinating layer of complexity to this already intricate system. What will that mean for how we approach these common problems down the road? Thanks for joining us for this deep dive. We hope you gained some valuable insights.